Shane's just gone to fetch Jenny Law's coat, so I will wait till she comes in, because obviously as a visitor, we'll look at the evacuation procedure. Fire drill is not expected, so if the alarm sounds, please evacuate the building quickly and calmly. Please use the stairs and do not use the lift. On one side of the building, please gather outside the Yorkshire Bank on the opposite side of the road. Exit by the door which you entered the room by. And if you need any assistance in evacuating the building, please make yourself known to a member of staff. Time to also remind members and visitors to make sure your mobiles and your retained levels set to silent, please. And obviously the meeting is broadcast with future broadcasting. Move on to apologies.
Councillor Hancock's chair with a substitute from Councillor Copland. Councillor Breenley, who's been substituted by Councillor Guttridge. Councillor Pomfret and Councillor Tracy Shepherd, chair, with substitute Councillor Watkins, but I think he said he might be running a little bit late.
I don't know if there's any other apologies. Moving on to declarations of interest, minutes, sorry, I don't think to go. So minutes of the last meeting held on the 2nd of November, members are happy for me to sign it as true record. Yep. To declarations of interest. Any member got any declarations of interest that aren't already in the paperwork? Councillor Guttridge.
Thank you, Chair. My wife's employment at the maternity unit at the George Eliot Hospital.
No items of public consultation, so I'm going straight on to item 6, improving stroke services presented by Jenny Lawson.
Hello, thank you. Thank you very much for inviting me here today. First of all, apologies are due that I believe that you have only just received the engagement report, so just to acknowledge that. So what I intend to do is just to give you a little bit of background to the stroke services piece of work, talk you through what's in the document and the engagement piece. Obviously, I appreciate you won't have had time to digest it and read it. So what I also propose is if there are obviously any further questions or queries that you want us to respond to after the meeting, then we have time to do that, then I'm more than happy to do so. This document is also on our website. It was presented as part of our governing body public meeting as well, so it is accessible. So I'm Jenny Northcote, and I was expecting another colleague here with me today who hasn't arrived yet, so I don't know whether they've been stuck in traffic, so apologies for that. But the stroke services engagement piece has come after a long period of engagement with a whole range of individuals, with clinicians, with stroke survivors, and a lot of GPs, as well as other people that have an interest in this area. The proposals are essentially about how do we support the best outcomes for patients who experience a stroke and provide the critical care that they need. Within a context of the specialist workforce that's required to respond rapidly to that initial need within a very small window when somebody experiences a stroke, but then also what happens then in terms of the rehabilitation afterwards and support for stroke survivors. The essence of the work that's been done around stroke is about ensuring they have the right care in the right place for people that experience a stroke and the rapid intervention that's required in the first few hours of somebody experience a stroke, but then how do you then repatriate them once they've had that initial critical care back into an environment where they can recover. And for most patients, if the care is given quickly and sufficiently, then they will be able to recover at home, but some people will need ongoing rehabilitative support as well. So that's a little bit of context and background. In terms of the document that you've got in front of you, it was a period of engagement, and it's engagement, not consultation at this stage, because we were still developing our thoughts and our proposals. So this is an engagement piece of work around presenting some of the emerging propositions around the stroke reconfiguration and the services to provide to try and support the best outcomes for patients, with a real focus on, as I say, trying to get critical care within the time period when it is most effective, but then support people to recover and optimise their recovery. So the engagement was undertaken in terms of developing the way we did the engagement with, as I say, stroke survivors, clinicians, etc. And the engagement process included a range of initiatives, from sending out a questionnaire, which also included a easy read questionnaire, but also doing some face-to-face events as well. Okay, I've started, just jump in. And this is my colleague. So the engagement piece included, as I say, sending out the engagement questionnaire, but also face-to-face events. It also included some media interviews as well, and also some online engagement. The responses that we've had have been, some have been direct from groups of people, such as HOSCs and other groups of people and interest parties, as well as individuals. It's really important to say that throughout this process, the Stroke Survivors Group and various other people with a significant interest in this area have been fully engaged in the process. And the document in front of you talks through the results of that engagement piece and what's come out of that. There has been around 4,000 or so copies or more of the questionnaire that was circulated, and I think we had around high 300s, 400s responses. But there's also, as I say, been quite a lot of face-to-face conversations with various different groups as well. The key things that have come out of the engagement, and I'll draw Kerry into this as well, has been people wanting to understand about the travel implications, the implications for carers in terms of support ongoing, particularly in terms of rehabilitation, but also to try and actually understand the proposals and the outcomes in terms of that sort of centralisation of the immediate service provision, and to be assured that that's based on good clinical practice, which it is. So the engagement piece really brings to the fore the ongoing considerations that we need to understand in terms of, if we're taking any these proposals forward, in terms of understanding how they impact on people and carers, and the next steps in terms of any formalising any proposals, which then might have to go out to a formal consultation. So this is not the end of the engagement process, it's a staging post in helping us look at those proposals, test those proposals, understand where any areas of concerns might be, so that we can then focus on making sure that we address some of those issues. As always, the issue around transport access is key. But I think what has come out of this process is a recognition that ultimately patients are focused and understand that when specialist care is required and needed, it needs to be delivered by a specialist skilled workforce, and that there is good evidence for that very critical intervention to be centralised and to be done by those specialists, but that the rehab offer and the care and support offer needs to be much closer to home, and that message has been heard loud and clear, and it's absolutely part of the proposals going forward. So I'll just sort of stop there. Is there anything else you want to add in terms of
Just
engagement?
the only theme that, and apologies I was late and travel on the A46, that's the theme of my life apparently. The only other theme that came out was just concerns about capacity and making sure that if there was a move of services that specialist support to University Hospital in Coventry, they actually had the capacity to be able to fulfil that for the additional patients that they would receive. So making sure that the hospital could always also recruit to serve that model as well. So they were another couple of sort of key themes that came out from the feedback. But as Jenny said, this is sort of part of the process, and we've been engaging with the public throughout. But what's really important about this report and the feedback that we've had is that it very much is feeding into the proposals. So when we do get to the stage of going out to formal consultation, the patients and the public that we've spoken to will have been able to influence right the way through the process.
I think the only thing that I would add to that is that already in getting to this point, there were two key things that, alongside the transport, that came out even before we entered into this engagement, and that was about the importance of the rehabilitation component, and that was actually something that was rethought and given more focus in terms of even these initial proposals. So I think we can demonstrate throughout the process how we've sort of listened and evolved some of the proposals going forward. The other theme that came out was around the sort of preventative element as well, and the role of primary care in supporting some of that sort of preventative work. And we are also, that's not specifically related to these specific proposals, it's part of the understanding of the broader system of care that needs to wrap around the way we provide services and look at preventing strokes and raising lifestyle issues, as well as then obviously having a really robust offer to patients that do find themselves unfortunately having that need to use those services. So as I say, it's quite a weighty report in terms of going through the responses and the themes coming out of those. But I guess the first part of the report in terms of the executive summary, and on page 13, what talks about some of the key issues that were raised, and probably some of the key things at a glance for now. But as I say, happy to pick up on any other questions or to respond to anything after the meeting if people have got any concerns, and to obviously keep you fully appraised of any next steps in the development of those proposals, and indeed any further consultation and engagement that takes place as part of the next phase of taking this forward.
Sorry, the members haven't got the whole document because it was about 50 pages, and sending it out to you today wasn't going to achieve anything, so we printed off the summary, just the recommendations for you for this evening, but you have had the link to the full document, and I believe that you now have a copy of the full document.
Hopefully you would have seen had the opportunity to contribute to the engagement questionnaire as well, so hopefully some of the questions will be, and the themes within the questionnaire will be familiar to you anyway, and will then be able to see the output of what you've potentially contributed to. So as I say, apologies that didn't come out beforehand. I'm afraid we weren't aware of that until today.
Thank you very much, Chair. I had actually looked at the electronic version, I've just had it on my tablet as well, and absolutely key seems to be transport and things like that. people who've got stroke understand they have to go to see the specialist. It's everything else that actually is the problem, and particularly with Rollsgrave and A46s and a large number of people in this town do not have cars, and as they get older and strokes are in the 60s and 70-year-olds more and more common, is when you don't have a car and your friends and relatives no longer have a car. So it's great doing this survey, but we actually need the solutions as well. And it's probably easier for some people to go to a specialist hospital in Birmingham where you get a half-hourly train service than try and go to Walsgrave where you might or might not get a buzz and your relatives won't get a buzz back after visiting you. So are we progressing the solutions to get a regular transport link from Nuneaton to Walsgrave that actually runs early and late?
So I'm not sure if I can specifically answer that very specific point, but what I will say is that an additional piece of work has been commissioned in terms of the understanding of the transport needs assessment as a consequence of this, to actually really understand that. Also to look at the specific requirements in relation to this in terms of what options might be available to support the transport. The other thing around this is, notwithstanding that we need a solution for whomever does need to travel, is that that certainly with these proposals, the focus is very much on being very clear about that short window of specialist requirements, and then bringing people back in terms of both in terms of the rehabilitation offer, but also in terms of the support in the home and wrapped round. So there's two elements to dealing with the transport issue. One is how do we support people in the 2 or 3 days when they might need to go and visit somebody on that particular site, and what are our options around that, and who's affected by that, and realistically what can we do about that. And then the second bit is the focus on trying to get people back home as quickly as possible with an appropriate supported package, so that they can be amongst their loved ones where that's appropriate for them to do so. So the transport element is a key issue that we're looking at, but in both of those ways.
Thank you, Chair. Thank you for coming on today to give us a presentation. I'd like to firstly express, Chair, and I do this respectfully, I am disappointed we didn't have the paperwork in advance. It's very difficult, especially when the summary document doesn't address Nuneaton and Bedworth. And obviously that's our primary concern. I can see Nuneaton and Bedworth mentioned in the executive summary. It is in the other document, but we needed more, and it would have been useful to maybe have an officer report distill that information for this committee. However, what I'd like to really understand, because obviously we're a voice for Nuneaton and Bedworth, and there was one consultation in Bedworth, I understand. However, there doesn't seem to have been many events or any events in Nuneaton. I also notice on page 14, 5.3, there are other community groups and venues that were used, and none of those appear to be Nuneaton, as well as a consultation, the public meetings where there was nothing in Nuneaton. And obviously we are Nuneaton and Bedworth, but we have our own public transport issues with people getting from Nuneaton to Bedworth as well. And it was highlighted from my quick skim of the full report. There were concerns in Nuneaton and Bedworth about we've got one of the highest rates of deprivation. We've got real issues about public transport, people affording to get to Coventry. I mean, it's £6-7 return. Never mind actually having to visit loved ones and not having the times. But also, previously, when I've spoken to residents, and these plans may have changed because I've not had time to catch up, and obviously they will come back to us in the future, won't they? So this is really for informing where you go. My concern is that we have an assessment bed at Nuneaton, my understanding, and while the number of beds will increase to 20, I believe, we will lose the assessment bed. And I believe, from people I've spoken to, there are real concerns about that. Because obviously people like to access George Eliot, we want to use George Eliot. And because of our deprivation status and our health indicators, we are at a higher risk of stroke. So having something here is really important, because if you have it in Coventry, people aren't going to be able to visit, and there are lots of problems around that, and I don't know how we can best serve that. But I also finally wanted to just comment on the document that I briefly read over, which is the engagement report. I'm glad that you've highlighted lots of concerns of the respondents. I'm disappointed there weren't more people that responded, as I'm sure everybody always is. However, my concern is that you've acknowledged the views of the respondents, but actually you highlight 2 points. First of all, maybe it's not at this point in time, but there isn't a great response to those comments. So, for example, it says here that while you accept that people are concerned about having treatment further away, equally you're suggesting that it's because they don't understand and that they don't understand the benefit. But actually that's not necessarily listening. We've got to listen to patients, and we have got to clinically justify it. My second concern, and it was reading both documents very quickly as I did, cost does seem to come up. Although it's said that this isn't in relation to the STP, or whatever it's called, better care, better choice, better name. The reality seems to be that there is a driver here about cost, and there's a real acknowledgement of the operating environment that you're in. And so while there's that vision or aim to offer services at home, for example, which is something I would really like to see, you equally acknowledge that there's a problem with affordability. So the question I've got there really is, what should we as a local authority be doing to lobby for more money so you can deliver a good service that meets the needs of local people, not a service that's driven by cost cutting?
So there's a lot of questions there.
Sorry.
No, it's fine. No, that's absolutely fine. I'll try and break some of those down if I can. So first and foremost, this programme of work, and I know potentially lots of people say this in lots of environments, and this may land as you accepting this or not, but on this particular programme of work, this has not been driven by a cost basis. It's been driven by a clinically understanding about where the best outcomes for patients can be delivered within the time frame of that optimum clinical intervention. And I'm not a clinician, so I won't sit here and try and profess to say all the different clinical components of that, but that has absolutely been driven by that. And the elements that are sought to be centralised are those components that require that absolute time-limited specialist intervention. And part of that is not driven by its cost, but it's actually driven by the specialist workforce requirements and equipment, etc., that needs to happen. And also the competence that needs to happen in terms of the number of clinically sound, optimum clinical skill. So genuinely, that component is absolutely about that. The rehabilitation component was definitely something that came out of the early listening exercises, because I think the focus was initially very much on that clinical component, but the rehabilitation element is really, really key. And that is also attributed to when care is given, because actually people recover quickly and have less ongoing impact on their physical outcomes if that care is given quickly. So this is not going to be a cheaper model for delivery, and nobody has ever kind of presented it in that way. And that's, again, I won't be able to quote the figures, but that's very much the case. The issue about the lifestyle issues and deprivation and the impact around our local residents and patients, I think that's something that particularly our CCG is very, very aware of. And that's why this cannot sit in isolation as a response to somebody when you're having a stroke, it's got to be part of the preventative lifestyle issues as well. And that's why I sort of mentioned the work we're doing in primary care, but we're also doing a lot of work with public health around those lifestyle interventions and those sorts of issues as well. And that's not about just telling people how to live their lives differently. It's about giving people resources and choices to think about the impact of lifestyle, life choices and life issues. And we know that that's challenging and more challenging for some people than others, and we need to put that support in. We've got a number of initiatives with public health and with our primary care colleagues where we're looking to provide those inputs and also to sort of work with people in terms of ensuring that through primary care we get that early intervention work right, and that needs to sit in this context. In terms of the public meetings and the focus and picking up on that issue, what I would say to you is that, and this is interesting, but actually the level of engagement that happened through the public meetings was not necessarily where the energy was in terms of the feedback and the engagement. That happened, I think, in lots and lots of other environments that we went out to. So I wouldn't like to give you the impression that the public meetings were the only interface with people. There was lots of conversations in lots of different environments through lots of existing groups where those conversations took place. And actually, on this occasion, the public events, because of the nature of the discussion, the types of people, sometimes public events are great, aren't they? Because they invite people to have the opportunity to come along. However, for this particular discussion, actually going to and working with the stroke survivors, working with carers and families groups, etc., was actually probably where we got some real richness of feedback. But I'll take on board your point about considering locations. As you say, in terms of coming back when our proposals are fully developed and formulated, we can certainly take that into consideration and think about where we offer those opportunities. Yeah. And what I would say is that actually putting on an event and asking people to come to an event is not always the best thing. It's about going to where people are and having those conversations in the places they feel comfortable. We did do quite a bit of that, but we need to do more of that. Particularly, the cohort of patients that we're talking about, that might be more vulnerable or might be frail or elderly, etc. So we need to go to those sorts of environments, and we will definitely take that into our next phase of engagement. What else did you ask me about? I think I've sort of said all I can say at the moment about the transport issues, just to assure you that we are looking at what those implications are. We're looking at the needs assessment. We're looking at how many people will be impacted in that short space of time. What options might be available to us. Haven't got anything firm to take today, but what I can assure you is that is something that is definitely on the radar for to understand and is not lost on us.
Thank you, Chair. Ida. I'd like to just some information on the summary report that we have, 1.5, and it talks at the bottom, bullet point, concerns about recruitment to serve the model. Now, I find it difficult to believe that the public were raising concerns about recruitment. How would they know that that's a problem or not a problem? So who was raising the concerns about recruitment, and why were they raising concerns, and what's going to follow from that? And I might have one more.
So the report, so it does summarise obviously the public's response, but it also summarises the response from a range of different stakeholders as well. And with any change to a model of this nature, staffing has to change as well to reflect that. So in terms of increasing staff at University Hospital and the additional needs of effectively stroke patients all heading to University Hospital for that initial part of their care. So the concerns were really around whether the staff at University Hospital could be then adapted in sufficient time to kind of meet those needs. Does that make sense?
And the response to that is, in part, it's about, as I've already said, in terms of parts about have we got the right skill mix and is it in the right place? And obviously, as we move from where we are now to a new transition model, we would need to ensure that that was in place before we actually mobilise that service. So that will be something about the plans to how we move from where we are now to where we would be if we indeed move forward with these proposals. But the other thing is as well is because the care, if it's offered quicker and in the right environment, people recover much, much quicker and then can go home quicker. So actually there is something about, it's not just about looking at the numbers, it's looking at the, this is probably not the right terminology, but the sort of the turnaround and the flow for patients through, because what you potentially have at the moment is people going into a situation, they might end up staying longer, whereas actually if you get the optimum care sorted with the right skills, then people can recover quicker. So you actually can cope with a higher volume of concentration with that optimum skill mix. But it's true to say that at the moment, you know, with anything, when you move from one model of care to another, the way you mobilise that and the way we develop that would have to be part of the next stage of plans. But obviously at the moment we're still engaging on those plans and developing those plans, and it would be and we are thinking ahead about what those next steps might be, and how they would be resourced and the sort of workforce implications, because that's exactly what we should be doing. But we can't finalise those until we've obviously presented those proposals, done the consultations, and actually been in place to say that is the way we're moving forward. So we're in that kind of combination phase at the moment.
If I could just come back, but I'm still a bit, I'm concerned about the concerns of professionals. Who were these professionals then? That's what I'm just asking. I understand your reply and I've taken that on board and whatever, but what I'm saying is that it didn't happen in public meetings, it didn't happen in whatever. Which group of professionals were concerned? Because it talks about recruitment, not, you know, reskilling or whatever.
I think I'm going to have to look back through the report and come back to you on which, exactly which of the stakeholders, if that's okay. Is that all right?
Yeah, yeah.
But what I would want to say is that in terms of the proposals, the clinical buy-in for the proposals has been something that has been absolutely central to this discussion all the way through. So again, we will need to come back to that specific point, but I wouldn't want to leave you with an impression that the clinicians in terms of the specialist clinicians aren't signed up to this as a model of care, because they've been fully engaged in that process.
I accept that, but then you can be signed up to something, but something else like recruitment, you can have all this will in the world, but if you've not got the people to do it, it's not going to happen, well, to the degree that you would like. Can I just ask, just below that, it talks about questions also being raised about this improvement fitting in with the STP. Now, the STP, whatever else it talks about, and whatever else they are, money, there's going to be less money. So you can call them cuts, you can call them whatever you like. There's less money. Now, everybody can have a different word for that. Now, that's a concern of mine, obviously. How does this then fit in with that?
Yeah, okay, so it is certainly true that as a health system we have challenges that we have to face in terms of increasing demand, in the increasing, you know, to celebrate the fact that health can deliver better outcomes for patients, and therefore gives more opportunities for people to live longer with more complex needs and require more demand. So it would be disingenuous to say that there is not a challenge around resources that aren't just about funding, but resources, workforce, etc. So that is certainly something that the SDP is looking at in terms of how does the system work better to optimise healthcare with the workforce that we've got and with the resources that we've got. and some of that is about doing things differently, some of it is about doing things that make the greatest impact, and some of those things are about making sure that we're not doing things twice and 3 times when we could only do it, we only need to do it once. In this particular instance, the stroke reconfiguration, as I've already said, it does sit within the STP, but the focus of this particular work stream is absolutely around the outcomes, the quality of care, clinically driven care, and is not going to be a saving to the system in the context of reducing the investment in this area. What it will do will be optimising people's recovery and rehabilitation. So in terms of a system-wide response, if people recover and need less adaptations, less social care, less other things because they are that their outcomes are optimised, then there will be benefits to the wider system. But in terms of the health component, this is genuinely been delivered by wanting to optimise the care in the right way to increase people's recovery and survival rates, and survival with better quality of life and less need for other resources that they might otherwise require. I think unfortunately, because it's linked with STP, it inevitably has that connotation, but that's just something that is unfortunate, really.
Councillor Ellis.
Thanks, Chair. I just wanted to comment on, you've just said it's about how the system can work better and bringing all the strands together. I didn't expect to have such a personal experience, but a couple of weeks ago I hadn't been feeling very well, and I tried to get a doctor's appointment, but I couldn't get one for 8 days. So a little bit concerned, so I just rang NHS 111 to check whether it was safe to wait for 8 days, and they told me they thought I was having a stroke, and to go straight to A&E. In fact, they were going to call me an ambulance, so I didn't think I was having a stroke, but they were quite insistent that it sounded like I was. So I went to A&E. When I checked in, the receptionist, they actually rolled their eyes when I mentioned 111, and I wasn't having a stroke. And they did say that this happens a lot with NHS 111. Don't worry, go and sit and wait. So this was George Eliot, which is a good about 10 minutes away from my house. And I was thinking at the time, thank goodness I haven't had to go all the way over to Walsgrave, because that's taken me over an hour. And on the back here, I echo what the Councillor Margrave said about the language. It says here that how to alleviate perceived transport difficulties. I think that's perceived is a little bit of a they are transport difficulties. So anyway, sat there for 4 hours, and as I've gone through the system, and I heard somebody else who they thought needed to be seen by a specialist was sent off to Coventry and Warwickshire University Hospital, and was told that they had to make their own way there. And there were signs up about that as well. And I think if it isn't about saving money, why is there not ongoing transport for those people? Because that was getting on for about 9 o'clock at night at this point. So it's about all the systems working together. 111, I think, needs looking at. I would not want to ever ring it again. I wasn't having a stroke, I'm all right. The kind of false economy model of not being able to get GP appointments and then going and being in that system, that wasn't necessary for me to have been there. And the whole, for me, I had to leave children at home. I had to get somebody to look after those children. But I was home by about 9:30 p.m. If I'd have had to go to Coventry, I wouldn't have been home till 11, provided, you know, I was seen in the same time scale. But whether it would be a lot quicker because it's specialist, I don't know. But I think I've probably covered everything there.
I mean, I think in response to that, I mean, obviously, it's very frightening when you have a personal experience, and it's very, and I think, you know, there's a whole range of issues that you cover there. If I try and take each one, but not spend too much time, I think that we absolutely need our primary care offer to be a good offer for people so that they can get appointments. There is a whole stream of work, which is probably another conversation to come back to at a later date in terms of primary care developments. But certainly there is work in train to look at how we build the resilience of primary care so that people can get timely appointments, and secondly how we can provide out of hours provision of GP type interventions so that people can access those at more convenient times, etc. There's a whole strand of work around that, but that's a challenge as well. So that's the. In terms of 111, I think it's unfortunate that your experience wasn't good in terms of 111, but certainly there's been a lot of work with 111 to increase the clinical skill that's on that face-to-face call in response to some of the feedback that the public have had around and wanting to have assurance about the judgments and support that 111 in terms of directing, because they're a key partner in the system. In terms of the sort of pathway you've described, I think in essence you sort of described some of the problems with the current pathway in terms of there's a lack of clarity about where people should go, under what circumstances, where they should, how long they should be there, and what specialism they need. Whereas what is envisaged in the new model of care is a much clearer pathway around the sorts of symptoms that are being expressed and where those individuals get directed to. Because, again, I'm not clinical, so I won't profess to understand this. Depending on some of the clinical symptoms, etc., then that's quite important in terms of the route people would get and whether they'd need to go to the specialist provision. Take your point about the language being laden with value, and we can pick that up in terms of at the end of the day, if transport is perceived as difficult, then it is difficult, because that's my experience, and I think we just accept that, and we need to think about ways around that. We have to be realistic about that. We have as health colleagues, we can link with our partners, we can work with transport colleagues, etc. And we need to understand the issues and the implications. So I think that's my response back to you, but I hear the messages that you've given us, and I think that just tells us about making sure that the system makes sense and that we're clear of the pathways and that all the partners understand those and work well together. And that's got to be something about the way we mobilise any service change.
Yes, thanks, Chair. I think it's your acknowledgement of the fact that rehabilitation needs to be closer to home. I think one of the things, I think I would agree with Councillor Margrave, that the key issues raised don't really reflect some of the issues that we raised in Nuneaton and Bedworth. And my recollection of the engagement document said that the initial, I understand that, the centralised initial service could be at Coventry and Warwick. There may not be enough rehabilitation beds at George Eliot, but the overspill could go to Leamington, which to me is further away and would create even more. I'm not even sure where Leamington Hospital is, but
Miles and Whitman.
I thought it was I wasn't sure whether there was more than one. But I think, you know, that is a real concern for us. If then the rehabilitation that you know you've identified, you know, is part of the package, is even further away. So, but I can't find anything. I did skim through the longer document before I came, but I think that's, and there was no clear indication of how the future needs and the beds, I can see the model, but how it was quantified, you know, why there were X number of beds, X number of rehabilitation beds, and I think perhaps in any future documentation it would be better for us to be able to see clearer how you'd arrived at that, so that, you know, we can respond more fully.
So thank you for that feedback. That's fine. And I think I wouldn't. This document probably shouldn't be seen in isolation, because the original engagement questionnaire set out some of the thinking and the modelling behind some of those assumptions, and we will need to continue to review those on the basis of understanding the numbers and the flow, etc. In terms of the beds with the rehabilitation, my understanding is that has been modelled in terms of the expected requirements, and in part is due to, as I said before, if we get the care right, then the actual demand for some of the rehabilitation shouldn't be quite so acute, because we'll be getting better outcomes and people will be going through quicker. But absolutely, understanding the numbers, the flow, etc., is something we've got to test out and continually test out in terms of that process. So I think there's an element of testing, understanding where the modelling came from, which I think is articulated, but it's just not in this particular document. Understanding how that impacts in terms of, if you get the optimum care right, what does that mean for the beds and the time, and then being able to assess whether that continues to stack up in terms of the proposals, which will be part of the next phase engagement as well. I think we can pick that up as well to give those reassurances. I think some of that information isn't in this, because this is just a response to the engagement, and it's not the and therefore our proposals in relation to the engagement are X, Y and Z. This is the initial engagement. These are some of the issues and these are some of the themes we need to pick up, and we'll go into that next phase. So just sort of put that sort of context to it.
Very brief, because I didn't intend to come back again. However, just to build on Councillor Elliott's point around people who drive to another location, there is the time issue, so the travel time. But there's also, obviously, and it's mentioned in the report, an issue around capacity of parking spaces available. And also, inevitably, there's a cost to car parking that's going to affect people. So what I would ask, if possible, is to provide this committee in the future, when the further work down the road comes about, is almost looking at the quality impact assessment, because various protected groups are going to be really squeezed by cost, by travel, by access. Finally, that also would be useful is if in the future document it also spoke to what can district councils or councils generally do, because we are a heart borough, and that's something to be proud of, and we do work around prevention. But how can we play a role in this, really?
Well, I think we certainly welcome the offer to be part of a solution, because I think that's really important, and I think absolutely, I'm not sure if I'm going to quote this correctly, but when you actually look at health, it's something like 30% is DNA, 40% is social determinants, and actually the bit that is the direct health impact is actually quite small. So anything around those social determinants and prevention, and would definitely welcome, is definitely part of the solution. So we would definitely welcome that conversation, and we will give some consideration to some particular asks around that. But I think it will sit in that prevention sort of arena. Certainly, and that sort of communication aspect. You are conduits to the public, and we would welcome that opportunity to utilise that. Parking is always an issue when you're looking at sort of hospital sites. And again, it will be absolutely something that we'll need to sort of understand. I've actually been to HCW myself and experienced the parking scenario today, so I understand that. In terms of quality impact assessment, absolutely. Any proposal that we do for any change has to include a quality impact assessment. We also include a quality impact assessment, so that's components. And also that, just to reiterate, that's where we're also going to look at the transport needs assessment. So there'll be a range of different things. it would be wrong of us to say we can solve every single thing for every single person. But what we absolutely need to look at is how do we try and respond to some of those issues and barriers as best we can, without compromising the clinical care and the optimum population solution for providing this service, and that sometimes is a difficult balance.
In terms of, just picking up on Jenny's point about that assessment, it's being produced as we speak, and will be ready for the new year, so the CCG is going to be looking at that in the new year, and then it's probably a good opportunity after that, once they've had time to consider it, to come back and kind of present that, and it will give that a bit more detail around some of the issues that we've raised.
Ingrid?
Thank you, Chair. Coming back to rehabilitation, I mean, you've mentioned about the upskilling of staff in Coventry and the numbers of staff in Coventry. However, you have mentioned here about training for carers. Now, that means you are going to need more district nurses than you currently have. And that's in a time when district nurses are actually leaving their jobs because their workload is too much and they can't actually give the quality care that they would like to give. The other point is that if you are training your carers, those carers are likely to be elderly themselves and they may not be able to cope. And they will probably try to struggle on because they feel it is their duty to do that, but the reality is that they can't do it. And therefore, they are likely to have problems themselves. So it will make a bigger issue, and that does need to be considered with the district nurses.
Definitely. So, again, I wouldn't want this piece of work sits in a system of other pieces of work that, as you rightly say, link and need to be in place. There is work with around carers and carer strategy that's being developed, and we've been a partner of with Warwickshire County Council. And certainly the sense of I don't know what the right terminology would be, but sort of the carers that are unpaid carers that support families, and how they support people with a number of health conditions is a really important cohort and group of people, and providing support to keep them well and able is key. So I think this needs to sit at that point that you make needs to sit alongside what are we doing around supporting carers? Do we know who our carers are? Are we providing them with the support and interventions that wrap around their support, which may be through a range of other sort of said sector providers, as well as and community support and community assets and all of those sorts of things. So I think your point about carers is well made. It is definitely something that needs to be understood in this context, and certainly, again, within primary care, being able to ensure that we support carers and that they have access to the interventions that they need to keep them well is certainly something we are absolutely aware of, and we need to sit that in the context of this too. So there is a strategy around carers and caring that needs to sit alongside this.
Just a quick point that was mentioned a few times, I think, early on, is actually if we concentrate everything to Walsgrave, we're adding a whole load of levels of problems, and obviously there's different work streams going on for stroke and a whole load of other services. We need to actually be looking at the big picture as well in terms of where the NHS is staffed, and just so that everything doesn't get moved to Coventry and the problems get worse. And so we really need to look, as a complement to this, actually what services can be brought back to George Eliot to actually take out some of those transport problems. And I hope there's actually a lot of work going on to actually get more stuff brought back to Nuneaton, because you've also got the staffing issues. You say, how can we recruit staff? There's a lot of staff who will not want to work at Walsgrave. Yeah, there are a lot of staff who don't drive. Yeah, there's a lot of staff who, and actually trying to actually balance it out so that actually we keep our hospital viable and we keep the NHS economy providing jobs in Nuneaton and providing services in Nuneaton is important. I'll say and Bedworth before anyone jumps on
So
me.
certainly I would absolutely agree with that analogy, and it's absolutely part of the system approach and trying to get the hospitals to work much more closely together in terms of being really clear about optimum use of each of the sites with the right sort of skills on those sites. And we have terrible habit of using all sorts of acronyms and statements to describe these things, so apologies for what I'm about to say next, but we've very much been talking about network sites in terms of understanding the specific provision that we provide and where it's best placed to provide it based on the clinical requirements and the specialisms, but also how do you do exactly what you've just described in terms of what else can be provided locally and when that's best to provide that locally and how to utilise those sites. So that is definitely part of the system thinking, and there's a lot of joint working and collaboration across the hospitals around those sorts of discussions. So certainly I think that's a point well made, and there's certainly something that is part of the thinking.
Melbourne member indicated. I'm just asking the timeline. So you're going back with this document. So when are you looking at going on to consultation?
So next stage is the integrated impact assessment that we've talked about, which will be considered by the CCGs in January. Once they've considered that, we've got a formal process to go through in terms of approval from NHS England. So we haven't got a firm date for that as yet, and we won't be in a position to go to consultation until that's happened. So it's taking it a step at a time, I'm afraid, in terms of the process, and NHS England is a formal part for us in terms of assurance.
So the next key milestone will be the integrated impact assessment and what comes out of some of those and how that informs the process. So perhaps in January, February we can give an indication of what we think the timelines are and some initial feedback on the impact assessments. I think that it feels like this is taking quite a long time, but I think actually hopefully that's about gives you assurance that we're actually not rushing to a solution and we're going through the various different stages with the appropriate engagements, and that we are reflecting on what we're learning as we go along as well, and that therefore it is a real process. I mean, sometimes we get criticised for already having our minds made up about where we're going to and jumping to that end solution, but obviously what we're demonstrating here is how the engagement is feeding the development of the process and how we're checking and challenging ourselves as we go forward, and that's the timeline that we're on.
I think members around the table have made some valid points, and obviously we'd like you to consider them as well.
Yeah, absolutely.
Thank you very much. Thank you very much for your time.
Yeah, thank you, and apologies again.
You're very welcome to go if you need to.
Thank you very much, thank you.
And then after I can move the breastfeeding friendly handbook to item 7, which I intend to do. So,
well, thank you very much for inviting me, and it feels I feel part of the local authority, because of course the local authority now provides housing service across Warwickshire. So, right, we've been working on this for a while, and what is key to this, I think, is having the local authority behind us. So, you've been talking lots about prevention, and there is masses of evidence out there now that is that suggests that women who breastfeed their babies are reduced risk of developing breast cancer, ovarian cancer, osteoporosis. Babies who are breastfed themselves have massive short and long-term health benefits. So when you're talking about Nuneaton Bedworth, which I cover the whole of Warwickshire, this is where I always sort of gravitate towards because this is where all the health qualities are. So, for example, across Warwickshire we have a breastfeeding support service, an early breastfeeding support service within the health visiting service, which we only have in Nuneaton Bedworth and North Warwickshire. They'd love to have it elsewhere in Warwickshire, however, financial constraints allow us to have it in the north. And as part of that, we've asked an awful lot of mums about how they found the service. They love it, but part of that is the fact that they always come back to, we'd love to know where we can go locally where we don't feel judged or we don't feel not very welcome. So we've done little pieces of work ourselves, but actually it all comes back to we need this to be quite big across the patch. So I've had lots of great conversations with the environmental health department, and they've been fab in saying, well, we can support you with that because we know where people go and eat and all the rest of it. So whilst we're out there asking lots of other questions, we can also ask them about, are you welcoming to mums who choose to come into your establishment and breastfeed? So that's sort of where we are at the moment. It would be great, personally, it would be great if you could bang the drum for Warwickshire and lead the way. And then I take it elsewhere around the county, but it would be great if Nuneaton Bedworth would really support this in lots of different ways, I suppose. So that's basically, it's there on page 13, it's how it will go. So, yes, I think.
Thank you, Chair. Now, I did raise this as an agenda item.
Yeah.
Now, I want to begin by saying that when I raised it as an item, it was breastfeeding friendly borough,
Yeah.
not town, so I don't want to leave out Nuneaton.
Yeah. Yes.
In seriousness, though, I want to start by thanking you for coming here today and presenting to us, Mary, because I think that's really important.
Yeah.
And it's good to open the dialogue or continue the dialogue.
Yes.
I was a bit disappointed there wasn't an officer report because of, if we were to undertake scrutiny, it's really important we know that what we do as a local authority and how that fits in with our policies. So I haven't got a clear understanding of that internally, but we've got you here to speak about the broader context, and that's really helpful.
Yeah.
So what I wondered is, first of all, what we could do as an authority more.
Yeah.
And that's possibly, we have responsibility for the town centres, so how could we work it in our town centre policy?
Yeah.
Although we have got few powers, and we've got very little money,
Yes.
we have got lots of reach, and we are part of the community.
Yeah.
So it's really about thinking, what can we do as a local authority within our policies, within our structures, within the people that we meet, to improve access. And it has been raised with me that actually under the Equality Act, people shouldn't be refused. But I had a situation many years ago when my goddaughter was sent by a member of staff not too far away in a cafe into the toilet. Well, I wouldn't want to eat my lunch in the toilet.
And that's always the scenario that always.
So really, it's it's about what can we do as an authority. I wanted to just bring it onto the agenda and try and make sure that we do more at this end of Warwickshire, in bringing on board businesses, and also telling residents what their rights are.
Absolutely. I think mums know that they have a right to breastfeed in public spaces, but it's how it makes them feel. That's the important thing. So you can go in somewhere. So we've trundled around in the past, and for example, there was one incident in Atherstone, and this woman who owned this place said, I know I can't stop them, but I don't particularly want anybody coming in here and doing that in my... So that already, you think, well, oh God, you wouldn't want to go in there because you're going to be made to feel very, very uncomfortable. So it's mothers' perceptions of how it makes them feel is the most important thing, really. So you could include everything where a mum might be going into, and what a local authority has, whether you can influence anything within that sphere.
because I think this committee can ask the Cabinet to look at this issue, can't they? Not make any solid recommendations, but to just consider the broader issue with the officers about, you know, the work we're already doing, just making sure that's in our policies and reflected, but also about what more could we do within our budgetary constraints.
So signage is always a good thing. So mums, when they're pootling around, can actually see, yes, that's where I want to go. I think having policies in place, so even if you think within your own organisation, having friendly policies in place for mums when they're returning to work, things like that is really, really helpful. But also then promoting that within local businesses as well. Because again, for mums returning to work, legally now there should be provision for a mum who's returning to work, if she's choosing to continue to breastfeed, that there should be provision for her to be able to express things like this. So, but again, it's there, but it's perceptions which is really, really important actually when you talk to mums. So I think anything and everything that you've got your fingers in pies is yeah. But I don't know how that would look.
Sorry, what was your last comment there? Your last sentence there?
Oh, whatever fingers, you've got in pies.
No, you said something after that. You don't know how it would...
I don't know how that would look like.
Oh, right, I see. Beg your pardon.
Yeah. Exactly I don't know how that would look like.
No, thank you.
Yeah.
I think it's a very good initiative, but I think a lot of these initiatives to the general public, they carry on under their radar.
Yeah.
You know, this Warwickshire welcomes breastfeeding, and it's all very well having a right to breastfeed your child, but it's making the public aware and for them not to be judgmental.
Absolutely.
And I think that certainly, unless I've missed it, I've seen nothing about this in the In Touch, which is our magazine for the council, to say that this is the county, the borough.
Yes.
This is an initiative that's going on.
Yeah.
I've learned a lot of things since being on this committee that I wouldn't have known as a resident.
Yes.
And I'm thinking, well, should I have known that? Not particularly. You know, and how would I have found out if, you know, it's all very well saying, well, it's on the website, but Joe Public doesn't go on the website daily to find out what initiatives are going on.
Yeah. And well, certainly coming, so there's lots of little things going on in the community that I'm sort of trying to bring together, and then getting our communications department, for example, involved to say this needs to go in the local spreads in Nuneaton, Bedworth and North Warwickshire, so that people can become more aware. Free papers, anything that you can, that you can place it.
I suppose that was just a comment.
No, and it's a good comment. Yeah, it is a good comment. Yeah, and it is. It's the general public that sometimes are the worst culprits.
And it doesn't have to be a cafe, does it?
No,
absolutely
not.
When mums are breastfeeding,
yeah, a park,
they're not, you know, the park
tingles,
or the museum,
anywhere.
You know, somewhere, perhaps the council owned places.
Absolutely, anywhere and everywhere. Yeah.
I was just going to say, we had previously a talk about dementia and people going around surveying that, so it might be quite useful, all the groups networking and actually making almost a bigger guide of, is it this friendly, is it that friendly?
Yes.
There's actually a lot of commonality, even though they're totally different sets, in terms of making the borough more friendly to all sorts of users.
And welcoming to everybody. And sometimes if you actually put them all together, so if you put somebody with dementia, somebody where there's an environment that's breastfeeding friendly, somebody who has dementia who then has got access to a mum with a baby, sometimes that is very, very helpful to the person who has dementia, interestingly. Yeah.
Thank you. When I read this, I was really surprised that there's 63% of breastfeeding mothers, because, I mean, it's not something you see everywhere.
No.
Yeah? But, and there is reasons for that.
Yes.
But any time I've seen it, and, it's been there, I've never seen anybody, even mutter under their breath or anything. I just haven't. But so I'm thinking 63%. But of course, they only need one incident.
Yeah. Yeah.
It's not as if it has to happen to them a lot. You know, actually, in a strange way, and well, I don't know how I'm linking it in my head, but it's actually a bit like racism. You know, somebody making a comment and you're not allowed, you know, something wrong in their eyes, and they're the ones that are wrong.
Yes.
And I think it's something that'll slowly change, and it is slowly changing now.
Yeah.
I certainly would support this. I don't see how this, I mean, it depends how far you go with it, but simple things like, I'm thinking finance in my head,
Yes.
yep.
Yes.
But if we have simple things like breastfeeding welcome here, that can't cost a lot. Blimey, they can make, it doesn't have to be a generic sign, it can be any sign saying that.
But we've got a generic sign
Oh, right.
already, and it literally, it's that signage there, that little logo, just on an A4, but it could be, you know, it could be smaller, but it just is something that.
Yeah. Well, however it happens, it's not an expensive thing. So I mean, I'm more than happy to go along with this.
Yeah.
Because reading some of the things here, it's quite striking. You know, when you talk about the benefits of it and that.
Huge.
It's not something I didn't know. It's something that goes out. You know, you read it and it goes out your head, and then. But we need to be getting it. We need to get the people that are, just don't
it's
welcome
a simple win-win.
Pushed to the side.
I think. Yeah, simple win-win.
So, how do we take it forward,
So
Chair?
I've got no other members to speak, so I'm obviously looking for recommendations to go forward to Cabinet member.
Can I just make a comment?
You can.
Chair? Mary's been dealing with Diane Coopey in environmental health.
Yeah.
Okay.
It was Diane that put me in touch with Mary. The reason that there wasn't an officer report is, or I understand, is because it is a very, very, very small element of environmental health's role, and therefore there is no officer time, as you to say, to give over to it. But obviously they've been, I think, trying to assist you by when they're going out and about to the businesses that they're visiting in town. We are trying to promote this. And so that is the assistance we're currently given. So that's just where we are at the moment.
Could I just ask a question? If I or anyone else knows a business that maybe doesn't know about this, but when they did, would be welcoming to it, where's the contact?
You can certainly contact me. You can certainly contact Diane in environmental health.
Okay.
Because the aim would be that we would then develop a little directory that would be issued to the midwifery unit. We would have it, children's centres would have it. So when you're coming into contact with mums, you're actually giving this information, so you know where to go.
Thank you.
Councillor Margaret.
Thank you, Chair. I think two things might potentially be useful. First of all is just to pass on our discussion today to Cabinet. And I'm sure that Cabinet are already aware of this, and really to look at how they can take some of those ideas on board. I don't want to tie Cabinet down into doing anything. There are lots of things already happening. It's just about being aware, really, that we've discussed it and what's going on locally. And also, I mean, I don't know whether a motion at Cabinet or a motion at Council, but it's about the leadership of this authority and us having a voice in the whole community, about just saying, breastfeeding is good. It has real benefits to the community. And backing up the women of this borough and saying, look, if you get refused somewhere, we're going to get behind you. I mean, I'm not going to describe how we get behind you, but as community leaders, we want to be able to celebrate breastfeeding and not shame people out of it. And that's just an important message. It's about the messaging and also about locally what we're already doing and just encouraging that. So obviously if there's a bit of time, there isn't much time or dedication to it. It's a very small element. It's about how can we support that to continue to happen? We've got a lot to do and we haven't got much money, and I appreciate that, but it's more about within the resources we have available, what can we do? And I think Cabinet are best placed to really look at that in the round. but it's just as a health committee raising it as an issue of health. Because I see it as both an issue of equality, but also importantly of health. And it's about our public health duty, really, in relation to if we can prevent dementia, if we can prevent the onset of other illnesses, just through breastfeeding. That's where it comes in my opinion.
Yeah.
In terms of practicalities, one of the suggestions we could make would actually be to get the labels on our buildings and also have some sticky labels. I mean, we have the food hygiene labels, 1 to 5. It's actually, I mean, the stickers don't cost much. Actually get some stickers that we could actually have in the van when they drive around or something. I don't know if there's anything to do with that, which is a low cost, but we'll get some visibility.
And Diane's already got some of those, just to see how they work. But yeah, they weren't. It didn't cost much at all.
So
And we provided that.
If we could actually suggest the actual stickers are distributed in some way, that'd be useful.
Yeah.
Still needs a recommendation.
Hmm?
If you wanted to go forward to cabinet, still need it in the form of a recommendation.
It's been proposed.
I think the recommendation that I was saying was that the discussion today goes forward to cabinet, potentially the cabinet member for health, but because you mentioned environmental health, I'm not sure whether it cabinet in the round for them to consider how we can, because the health committee. So this health committee has highlighted the importance of breastfeeding in prevention of I don't know what it's called, diseases, but
many short and long term.
yeah. So that, and we're just letting cabinet know and see whether we can do anything. Obviously, that's not the form of words, Chair, but I'm sure you can put that into a nice form of words.
I'm sure she'll put that in strong words, yes.
And it'd be nice to add a bit about proactively labelling, because that's...
Yes, absolutely, yeah.
And can we add that it's in the In Touch? I think that's really good.
Yeah.
I think.
Yeah, definitely.
That was actually put forward to go into In Touch when we had our initial. I don't know whether perhaps I thought it had gone in this last time, but maybe it got. I know some stuff got took out to make it more streamlined. I think, but so maybe it's in for next time. But yes, something will.
So is everybody happy for that recommendation to go forward
Yep.
to cabinet? Yeah. Thank you very
Can
much.
I fly out of the door?
You can.
You don't want to stay for the whole
If
thing?
only I could! That would be great, wouldn't it? Thank you very much indeed.
Or you're going to have to run now. Have you got your?
Do you know what meeting I'm going to? You're all like this, well as women. I'm going to a WASPy meeting.
Good.
Yeah, do you know what that is?
Yeah.
You do? Yeah, I'm going to one of them. So,
Well, we're going to stay and grill Chris over the ST picnic.
thank you very much indeed. Thank you.
Move on to
Have a good
item 8, Health Watch. Chris.
Apologies for being late. I've actually been out talking to patient groups, which is kind of what we're here for now. What I'll do, Chair, if it's all right, I'll do a very quick bit of background about Health Watch to make sure everybody knows what it is and where we are at the moment. But then what I think I'd really like to do is to have a discussion about the feedback I'm getting from patient groups in Nuneaton, but also more widely than that. And to see if they're of interest to this committee going forward. So Health Watch was set up by the 2012 Health and Social Care Act to be a consumer champion for anybody who uses health or social care services. That was our purpose. And we've been running in Warwickshire since April 2013. We have, over the last 2 years, suffered a significant reduction in our funding. We've lost a third of our funding in the last 2 years. And so that has inhibited our ability to go out and do the stuff that I think we were originally doing. But I think that's common across public services in general, really. And what that's meant over the last year is we've had to focus down much more on particular things. I set myself a target at the beginning of the year to visit every patient participation group in Warwickshire in the space of 12 months. We're now 11 months on and I've only done 36, so I'm going to have to get a move on in December if I'm going to do the other 44. But I have got an awful lot of really interesting stuff back from going out and seeing the PPGs. And we've also been trying to influence the STP, which everybody will know and love, I'm sure, to try and make that a plan that is more responsive to public need. We've done a significant amount of what we're calling enter and view, which is sort of inspection visits into care homes. We visited every GP surgery in Warwickshire, and we did 6 days at Coventry and Warwickshire Partnership Trust, going onto the wards and talking to the patients there about their experiences of the Partnership Trust. And if you want to see our report on that, it is on our website. All 57 pages of it and 42 recommendations. It's well worth a read. We've done a fair bit of work with the Health and Wellbeing Board to try and focus them down on something that really matters. And that's a little bit of a challenge, and a lot through HOSC as well. And on top of that, we've responded to about 1,000 individual queries and visited a lot of seldom heard groups. So it's been quite a busy year, whilst we've been restructuring and trying to adapt to the new funding regime we're facing. So that brings me on to the future of Healthwatch. At the moment, we're tendering for the Healthwatch contract. And a decision on who gets that contract will be made sometime in February. So at this point, I'm talking to you and suggesting what you might want on your agenda, but I may not be around to pursue it with you. But I thought it was worth coming to actually talk about it anyway, because that's what patients are telling us the key issues are. So what we're going to do, assuming we get the contract and we go forward, we've pulled all of the patient participation groups in the county of Warwickshire together into a single standing conference. Because what we wanted to do was to ensure that all those patient groups had a real say in the way health and social care is developed and delivered in Warwickshire. And the best way of them doing that is to stand shoulder to shoulder and talk about their experiences and what they wanted to see. The first of those standing conferences was held on the 25th of November, and we had a packed out room. There were a lot of people there. And I'm happy to ensure that the notes of that meeting are circulated to all of you, because there was some really interesting stuff coming back, particularly from people who said it was the first time they'd been listened to. So I think it was really worthwhile doing that exercise. We are going to continue with our focus on mental health, because the Coventry and Warwickshire Partnership Trust's CQC visit did not go quite as well as we'd hoped it would, and they have been rated as requires improvement again, as they were last time around. So we've offered to work with them to see if we can actually help in some of the areas where they still need development. We've improved, I hope, our information and communications quite significantly. And we actually have a social media presence now, which we didn't have before, because I didn't understand social media. But I've now got a young person who does understand social media. If they get to understand it as well as my 11-year-old boy, we'll be in business, I think. So we've got a really busy agenda going forwards. And I'm going to continue my visits to patient groups and community groups to talk about the issues they think are really important. And my real purpose in coming here today is, apart from whinging about our funding, is to talk about the key issues that those groups have raised. Now, these are not in particular order, but there will be a couple I will draw attention to, because I think they have come up again and again and again. So the first issue is what's now known as delayed transfers of care, which is discharge from hospital. It used to be known as delayed discharge, and before that bed blocking, but it's now delayed transfers of care, or DTOC for short. And delayed transfers of care, all of our acute hospitals are missing their DTOC targets at the moment. And it feels like the stakeholders in the health and social care economy are looking for places to place the blame for this. Now, the analysis that's been done by the Health Service Journal about delayed transfers of care suggests that around 60% of discharges, delays in discharges, are caused by NHS processes and 40% by community or social care processes. And I think that's quite an interesting one, really. And it's one that we need as a system. It's no good just saying to the hospitals, sort out your delayed transfers of care, because they can't sort out the bits that are beyond their control. So it's a whole system approach. And I say to you, as I go round, I say to every local authority, you may have a role to play in helping with this. Because one of the key issues around delayed transfers of care and being unable to move people around is around housing. It's around support when people are actually there. And whether that housing remains fit for purpose for somebody whose abilities have changed while they're in hospital. And that's a reality. There's a linked issue with DTOC, which is around readmissions, which have been, they tend to go in spikes, really. Where it's really cold weather, readmissions are more common, which I guess you can't expect, really, I guess. But a readmission is, technically, it's anybody who's readmitted to hospital within 30 days of discharge. And we do have a problem with readmissions in Warwickshire. I think in all of our acutes at the moment. So there's one issue that patients have come up and said, this is a problem, this is something we're trying to deal with. Second one is end-of-life care, which is patchy and uncoordinated across Warwickshire. That's the history of it, it always has been. There's nothing new there. But I think the north of Warwickshire suffers particularly in respect of end-of-life care. There are no end-of-life care beds where there are in the south, and I think that's an issue. And it's a long-standing one. I mean, talk to anybody from the hospice, the Mary Ann Evans Hospice, and they'll give you chapter and verse on this. So it's a long-standing issue. But again, it's a whole system thing. We can't say to the NHS, sort out end-of-life care. We all have a part to play in that. Right down from West Midlands Ambulance, who I'm trying to drag into this particular discussion, through to community nurses, through to social care, and through to mental health services. Because the mental health aspect of end-of-life care is particularly significant and spikes towards the end of life. And that's been highlighted by a number of patient groups. That's an important one. The third one is one that I would highlight and ask you to very seriously consider taking forward. You've mentioned it already, and it's about transport. And I have not been to a patient group who haven't mentioned transport so far. And it is particularly so in the north part of Warwickshire and in the rural south of Warwickshire. And they're saying, and I looked at the STP hoping, having made this point a number of times, hoping to find specific references to transport, but it isn't there. I'm told it's part of one or two of the work streams, but for me it is of sufficient importance that it should be there as a separate heading. Because if people can't get to a facility, there's no point in that facility being there. So no good upgrading the facility if no one can get there. So transport, I'd really urge you to take as a serious issue forward. Well, these are all serious issues. But that one in particular, and one other, I would say, I would ask you to pay particular attention to. The fourth one is one that we can't actually do that much about because of the scale of it, is the STP itself. Our objection to the STP was that it came out as a fully formed plan without any public engagement. And we objected very strongly to that, because I don't think that's right. It's our money that's being spent, and we should have a say in how it's being spent. That's NHS England's decision to keep it secret and not to involve the public. I think that was a bad decision, but I think it's now time they slowed the STP down and made sure we all had a say in it. And I actually think my earlier reference to standing conference, if the STP board are smart, they will use that standing conference as a sounding board for some of this. The next one, very quickly, I'll whip through these very quickly because they're not particularly cheerful this time, except that. There was a lot of concern expressed in a number of patient participation groups about new housing developments and the availability of medical facilities for that new housing, and in particular primary care facilities. Now section 106 money should be able to do something about this, but I'm looking at some developments and I'm struggling to see where the access to primary care comes from. The fastest growing place is at the moment is Rugby, and they've got a huge mast site, but they're losing primary care facilities, not gaining them. So I'm actually concerned, really concerned about Rugby, and I think the whole north of the county again is seriously under-doctored. The sixth one is one that I think everybody understands, is health inequalities. It bothers people, inequalities both in provision and outcome. And I think there are particular inequalities between the north of Warwickshire and the south of Warwickshire, which need to be addressed. But I think I've been saying that for 25 years now. But they remain of concern to people. The second last one is waiting times for assessments and referrals. People are saying they're waiting far too long for their assessment and referral, and getting into the system is often quite difficult. Once you're in, it's a fantastic service, but getting in is another matter altogether. And the final one, and this is the other one I think I'd urge you to take up, is, and it's come up I think in almost every patient participation group I've been to, is the crisis in primary care provision and general practice. And that falls under several categories. There's a recruitment crisis. People don't want to be GPs anymore. And I understand why. 84% of people who are leaving the professions are doing so because of workload and bureaucracy. And that's what they're saying, not because there are too many patients. It's bureaucracy that's driving them away. And I was reading that 2/3 of trainee GPs in the West Midlands don't plan to work in the NHS. They want to go and do something else when they finish their NHS training. So there's a real challenge longer term about primary care provision. And I think what we collectively as a system have to do is to move people away from just wanting to see GPs. Because for almost half of the queries that GPs get could be dealt with elsewhere. By nurses, by pharmacists, by social workers, by mental health workers, by a number of people, and they don't need to see the GP. And at the moment, our GPs across England do 1 million patient consultations per day, and we don't have the capacity to do that. So we have to find a way of encouraging people when they have a healthcare issue to go elsewhere. And we were at a meeting earlier on this week, and community pharmacy was saying we can play a role in this. Well, of course they can. Somebody was saying to me that the top community pharmacists, the best community pharmacists, do 4,000 hours of training, and a GP does 5,000. Well, they're more than capable of helping with the majority of health problems of pharmacists. So we should be encouraging people to make more use of them. And we had a very interesting, I was at Chancery Lane PPG earlier on this afternoon in Nuneaton, just down near Camp Hill there. And they came up with a very helpful suggestion about working with the school governing bodies to go there and talk to them, and to talk to their pupils about the right response to an ill health problem. It isn't, you don't have to go to your GP every time. A nurse can give you a good experienced nurse will take one look at you and tell you what's wrong with you. So it's worth doing that, and a good pharmacist is the same. So there are other ways of dealing with it, and we have to try. I think the answer to the recruitment crisis in general practice, the answer to that is to make it a more attractive profession. And the way that we do that is to take some of the pressure off them. And we could all help with that. I've talked to the Royal College about this. We could all help with all of this. The Royal College could help a bit by not having so much bureaucracy, but that's another matter. So we could all do something to help our GPs. They want to get this right. They want to provide a good quality service. But the fact of the matter is that 40% of male GPs at the moment are over the age of 50 and planning to retire within 10 years because they don't want to do the workload. Well, let's help them. Let's sort out a way in which we can support our GPs and keep them in our communities. That's where they want to be, and that's where they belong. So that's what I've been talking about with patient groups the last year now. And as I've gone along, those points that I've identified just keep coming up again and again. I haven't heard anything new for a while now, actually. So those points, I think, are the ones that people out there are saying are concerning them as patients.
Any member? Councillor Margaret.
Thank you, Chair. I'm going to do something unusual rather than just debate this out, because I think you've given a really extensive report. And I won't necessarily move it now, but I want to make people aware that I think it'd be really useful if there are 3 things that we did as a committee. First of all, I think we've got to look at this, the GP issue. I mean, my own surgery, Red Roofs, has closed its books. Others, I believe, are doing so or have done. And we, as a council, can at least play a role in attracting GPs here. Why is Nuneaton and Bedworth a great place to live and work? And why are we a great community to tend to?
Absolutely.
But also, the 2 other things that come to me really is, first of all, the recommendations that you've explored today. But I feel that would be really useful if we could share those recommendations with other OSPs across the council and asked if they could look at them. The reason being is, so for example, housing is an important issue in relation to discharge. So if somebody's not got an appropriate home and they were a council tenant or even a private sector tenant, we needed to do something to speed things up. How can we play a part? Or our plans in relation to development, what can we do? So it's really thinking throughout the council about how we could do that. It may be that instead of going to all OSPs, it could just be a day where we brought all councillors together. But it's really about thinking how we as a local authority can respond to those recommendations. I've not seen them all, and we can't do everything.
No.
But equally as a district, there are some tiny things that could maybe make a difference. We also need to use our voice to lobby the county. And I'll speak about the county later and the response to the STP on another agenda item. But finally, I also want, as a committee, or would like us as a committee, we've previously praised Housewatch and the work they do. And I do think, Chair, that we as a committee need to raise concern at the funding cuts to Housewatch, who are a vital voice for patients, and they achieve quality because of the work they do. And I'm really concerned that they potentially could lose, the current team could lose their contract. And I feel that we as a committee need to express that concern. It may not make any real difference, but I think we need to celebrate the work you do and commend you for it, and also express concern at the constraints you've got because you haven't got the money to do it and you might not have the contract going forward. And I think we really need you in place to build on the work you've been doing. So that's a recommendation I'd like to move either now or later, but hopefully it'll help shape a debate.
Any other member? Councillor Goldgood.
Right, firstly I'll mention we had a meeting at the beginning of the week at the County Council because they're looking at the issue of GP provisioning across Warwickshire. And it's very interesting, and that should get some paperwork produced maybe in March, who knows. But it is a big issue, and we shouldn't duplicate what's going on, we should add to it. So I think it'd be useful for that piece of work to be reported back to here, because obviously they have different responsibilities. We, as a borough council, the housing issues and a lot of those are really important. There was some good schemes ages ago, like prescribing GP boilers, and there's all sorts of good ideas, but there's no money in the system. The whole system is sinking, and we really need to give our MPs a massive kicking to actually make sure we fund the NHS and all the other things that support the NHS. A few individual things. I mean, I'm a massive campaigner on transport. We now have more buses running to the George Eliot, I think, than has ever been running to the George Eliot. The 65 now comes all the way from Tamworth into the George Eliot. And we need to promote those services so that actually patient watch people know we've got better services, but then carry them through to the Walsgrave, because transport is a massive issue. And finally, a lot of stuff with CQC. It's really good having these QC report saying mental health is failing, this is failing, that's failing, this care home's failing, but we actually need a massive resource to actually try and get these things sorted. And at the moment we're just signposting where all the fires are.
Can I very quickly respond to that? The CQC report on the Partnership Trust was actually quite an encouraging report, despite the fact it still requires improvement. What it's saying is that the Trust are trying really hard and they're listening to people. So I think some sort of dialogue with the Partnership Trust from yourselves about the challenges in Nuneaton would be helpful, because they are listening. They actually listen to us. We made 42 recommendations in our report and they've implemented all of them. Within 6 months they've implemented a lot. Now that's, I can't think of any other provider that's done that. So they really are trying really hard. I think now is the time to get alongside the Partnership Trust and to help them move forward. Because I think the door is wide open for them for you to go in and have that discussion with them. And I'm sure they could improve their provision in this area.
Any other member? No? I wanted to move a recommendation, councillor.
I move that the recommendations from Health Watch's report, feedback and report in relation to feedback from patient groups is shared with all members of the council. So that report is widely circulated. That will allow members then, if they would like to raise an agenda item, to do so. And I also move that this committee raises concern at the funding cuts to Healthwatch, who are a vital service in giving patients a voice and achieving quality.
Members happy with our recommendation? Yeah. In terms of discharge policy, protocol, reduction in pharmacy funding, we've got them on our work programme already, so we're guessing they've also got teenage conception. We've got an awful lot of stuff related to local hospitals, so.
And we did look at end-of-life care.
Yes.
Right, good.
So, and we moved the first council to look at end-of-life care.
Yeah.
So.
Nuneaton Bedworth ahead of the game as usual.
And I was just going to mention again, it says there's work going on at the County Council, which should probably report back here March, April, whenever it's done, because they're covering the same area, but actually calling witnesses and doing a lot more sort of detailed stuff, particularly on the GP provision aspect.
Can I move that in my recommendation? Because I did mention it at the beginning but forgot the end. But I take on point Councillor Condacor's comment in relation to the county looking at it. So, and we've not got the capacity in our agenda this year, but it's useful to.
But it might give us the ability to add bits that we want in there. Moving forward.
Would it be helpful, because it's been mentioned about it going to all the OSPs and that, and this, I don't normally sit on this one, as you know, and, well, it's been an eye-opener, reports and things like that, although I did remember, I must have come once before as a guest, because I remember the end of care one, because that was very close to my heart at the time. But would it be helpful us having a councillor seminar on the whole issue? Now, it doesn't have to be a whole day, it can be a half a day, or however it's decided, because these are massive issues that are really out in the fore with the public. They're there.
It's a really good idea. I support that wholeheartedly.
I'm now looking at Chris and saying, would you be available to maybe run some sort of seminar for us?
I'd be delighted to do that.
Councillor Ali.
Thank you. I just wanted to ask how often you have to tender to run Health Watch?
This is the first re-tender. The original tender was issued in April 13 for 3 years, but they extended it for a year. But now they're obliged by EU procurement regulations to go out again. What we don't know is if anybody else is going to bid for it. But I think even if it changes hands, I think the issues that we've discussed here today, we will be pressing very firmly that those are taken on board by whoever gets that contract, because I think the long term.
I'm just going to thank you very much for your time.
Thank you very much.
Thank you.
Moving on to the health store fund, Rachel Robinson can send us a briefing note. She has included the public health update for Nuneaton and Bedworth Health over the Scrutiny Committee of the 7th of December, and there's 2 lines within there that says, in principle, for hazard space and the health store. We'll work through details in the agenda item on the 19th of December. So I think it's a case of we're going to have to just keep an eye on that as to whether we get the funding or not, or whether we're going to have to press for more funding. I would have liked a little bit more detail on Rachel, but it wasn't forthcoming, I'm afraid. And on to item 10, update on the sustainable transport plan or better health, better care, better value. This is now, you've got the letters in front of you. This is the, if members want me to read it out, or you're happy to look at it, and I'm happy to comment we made in the panel. That's the one.
Okay.
So this has come back from Councillor Second. We're still awaiting the response back from Andy Hardy.
Chair, in relation, I thank Councillor Second for writing to us. And in response to her offer, if I can be of any further help in your discussion and debate on this topic, please do contact me again. Could I ask that the committee then, that we contact her again and ask her to come before us again? And if she, as the person who is sort of leading this area of work, because I think before she was mentioned as somebody who is sort of strategically leading, and then there's sort of an executive director or somebody who's then doing at that level. If we could ask her, as a strategic lead, to ask her officer to come before us, either full council or this committee, that would be really useful. But I thank her for her kind offer. It's very welcome.
Go along with
Happy
that.
to go along with that.
Yep.
Right again. I was disappointed. Well, I've got concerns that they're calling it better health, better care, better value, but you relate it to the SGP at the bottom, so I'm still not quite sure what they're calling it. For information in terms of the adult social care and health OSA, I've sent you the minutes from the meeting on the 6th of the 9th for information. Move on to item 12 in regard to the forward plan. Any member? Item 13, the wage programme. Amended. We are looking at a new thing for another meeting, so obviously I can do there as well, or else on the agenda. We'll have to try and take some of those off before our final meeting in March, so we're looking at the 24th of January. 29th, I've got the 24th.
Oh, right, okay, 24th.
So, 24th of January. There's also cabinet that evening, but if we don't do it then we can't actually get it until the next meeting, until the beginning of March, so that would be 2 meetings in quick succession. So that's our best option. That's the protocol.
If we're doing it on the same night as the cabinet, can we make sure it doesn't happen at the same time as the cabinet?
It'll be 5 o'clock as normal scrutiny meeting.
Because quite often cabinet does a lot of very important things, particularly January time. And so I would like to make sure we try not to clash as much as possible. And if we could start at 4 o'clock, that would mean we could potentially not overlap.
I think we've got to consider members that work as well. I think that would be difficult for some members to get here because they work, which is why we always say 5 o'clock. Yeah, if I can find another date, I'll sit down with Shirley and have a look, but we're in it, as you can imagine, we're running out of time at this time of year. So, but I'll do the best I can. Councillor Alice.
24th of January for this February the 18th. These items. Is that what you're talking about?
Yeah.
Yeah, but it was either we were looking for the date, beginning, the end of January or the beginning of February, and we're
Right. That's a
Southern.
Wednesday, not
No,
a
it was
Thursday.
2018, February 2018, not February the
24th of
18th.
February, not January.
No. On here, it says February 18. That was February 2018, not
Yeah.
February the
Yeah.
18th.
Yeah.
But we've now looked at the diary, and the 24th of January is the date of Cabinet, which is a Wednesday, because there isn't another Thursday free.
Oh, right, okay. Okay, so a Wednesday is proposed. Right.
Yeah, I'll sit down with Shirley and we'll have a read up, see if I can jiggle it about a bit. But we are struggling for dates and times at the moment, so I'm just making you aware.
Chair, in relation to the, because obviously it was interesting, the briefing note, it's very disappointing that it didn't have more detail. What it did have, which also lacked detail, but it highlighted the issue of male suicide. And obviously we're looking at suicide prevention.
Yes.
But could we ask, if possible, if they could give us more detail?
They will
Well,
attend that. They've told me
okay.
they will be sending somebody to that meeting. Was there anything specific you wanted me to?
Well, it's just, they've highlighted it as being among certain ages as being the sort of the first, sort of the most important issue, and yet while there are some things in the report around what's being undertaken, it was very confusing really. It didn't seem to really address the issue. It was sort of this headline concern about male suicide, and the actions didn't fully seem to meet up with that. And then it also mentioned the STP mental health strategy, but obviously the STP isn't completed, so it was sort of what is actually happening if this is so bad, which it is. Sort of waiting times and things like that weren't really mentioned in here.
No.
And I was hoping we wouldn't just get this again.
No.
Another quick point, if we have two meetings at the same time, only one of them can be video recorded. So there are, and a lot of important stuff on the Cabinet Committee, like the Community Infrastructure Levy. So I do urge again, we can,
I will do my very best.
or potentially start the scrutiny at 6:30 after the Cabinet.
Cabinet only half an hour.
It's been as short as 6 minutes.
As I said, I'll look at the dates and I have no any other items, it's just
Sorry,
push you.
is the 24th of January still provisional or is
Provisional,
it's still
but I'll
provisional?
sit down with Shirley when it's time for the day.
And there's 1, 2, 3, 4, 5 potential items to go on the
Yes.
agenda. I've got quite a few parents that really want to come along to the CAMS, and they're asking for the dates. They've got to arrange childcare and so on. So as soon as we can have the date, that'd be helpful.
So I've no any other items. I can thank you very much for your time. Season's greetings, and I think we'll go for a healthy new year. Yes.
Only time.